Hi, I'm Bob Harrington from Duke University and the Duke Clinical Research Institute. A few months ago, we recorded an audio show, an iPodcast on the Heart.org radio on the topic of global chronic disease, both management and research. And we had with us two cardiovascular fellows who had been training, one in Asia and the other one in Africa, to discuss with us some of the issues around the global burden of cardiovascular disease, some of the training opportunities for U.S. scientists, and began to explore some of the notions that the world is becoming increasingly smaller, the diseases of the West are the diseases of the world, and what do we as a global cardiovascular community have an obligation to think about with regard to both the spread of vascular disease as well as perhaps some of the research issues that can be done in vascular disease. So I'm really pleased today to be joined by two colleagues who had joined me on the Heart.org radio. First is Mark Huffman from Northwestern. Mark is a cardiovascular and preventive medicine fellow at Northwestern University. Thanks for joining me, Mark.
Thanks for having me.
And we'll come back about where you did your training, your global health training, in a few minutes.
Yes, sir.
Next to Mark is Jerry Bloomfield. Jerry Bloomfield is a cardiovascular fellow at Duke University and the Duke Clinical Research Institute, so I know Jerry well. Jerry, thanks for joining us.
Thanks for having me.
Although with your world travels, I don't see you as much as I see some of the other fellows, and that's going to be what we chat about today. So there's a lot of topics I'd like to go through. And the first one I'd like to go through is the global burden of cardiovascular disease. Most of our listenership reads the statistics. You guys have lived the statistics because you've been, you, Mark, in India, you, Jerry, in Africa, have really lived in communities that are suffering from vascular metabolic diseases. Put a face on it. Talk about the global burden of vascular disease and metabolic disease in India. Off camera, we began to talk about diabetes. Maybe weave that into it.
Sure. So heart disease is the leading cause of death in India, and that's a recent transition, overcoming communicable diseases as the previous leader. And I think while we see heart disease as a real problem, that's also the successes of maternal child health programs, infectious disease programs. So people are old enough to be able to actually live to get chronic diseases. Now the face of it is that people who get heart attacks in India tend to be about 7 to 10 years younger than people in the US, for example. And so with that, there's a lot of economic and family costs that are associated with that. It may be a father who's in the prime of his... So
it's not a disease, you know, we think of it now, acute coronary syndromes, for example, has a median age of onset in the U.S. of about 68.
Right.
A quarter of the patients in the U.S. over the age of 80. It's different in India.
Yes, yes. So it's closer to about 60 years old. Some data that we have is a little less than 60.
So now, as you say, that there's not just health consequences, there's major economic consequences, which may even be more devastating in the U.S. because the economy is really, is emerging, is really trying to improve itself as a global player. So it may be really serious consequences.
Right.
Talk about the diabetes story in India, because I've been struck by the diabetes, and I've been struck by the fact of obesity, and a particular type of obesity in India, which seems to be related to diabetes.
Sure. So I guess the concept of central obesity, some of the risk factors that are associated with it are the traditional things like central obesity, driving diabetes, and age, but even the concept of the Barker hypothesis, where an intrauterine fetal growth is restricted in stunted women, and so that seems to confer greater risk for Indians to develop diabetes, for example. And so that's something that it's been interesting to learn about, these concepts, that there can be transgenerational risk factors that are carried from mother to child that we don't really think about too much in the U.S.
And we talked off camera about there's a website that tracks the global epidemic of diabetes, where you can actually look at maps of the spread of diabetes. It's striking where India and China are emerging.
Yes, unfortunately, sort of neck and neck for the top, and it seems as though the predictions are pretty frightening. So
it's very frightening, and if you think about from a news media perspective and from an American cardiology perspective, we really think of diabetes as an American problem associated with obesity. But it's not. The world's problem is going to be in Asia.
Yes, definitely. And at lower BMIs probably than we're seeing in the United States and in Europe.
And the final question before we go on to talk to Jerry and his observations from Africa, I've been over the last few years to a number of courses dealing with interventional cardiology, and the burden of vascular disease. This is an observation, not based on empirical data, but the burden of vascular disease seems to be greater. More diffuse coronary disease, smaller vessels, very diffuse atherosclerosis throughout the coronary tree. You spent time there. Is that your observation?
It is. Very small coronary arteries. Now, there's a myth that Indians have smaller coronary arteries compared to U.S. or Europeans. And if you look at coronary arteries adjusted by body surface area, in normal coronaries, it's the same. But there seems to be a different negative remodeling process compared to more common positive remodeling that I think we see in the cath lab in the U.S.
So you've set us up nicely for something I'm going to get back to later, and it's this concept of the bidirectional flow of information. While a traditional global health approach has been, let's go to countries who are suffering from infectious diseases, communicable diseases, and help with the public health issues, help with the sanitation issues, help with the vaccination issues. Now we're really talking about something, yes, we can help in some of these areas, but our colleagues in these areas can help us maybe understand these diseases better.
Absolutely.
Is that fair?
Absolutely.
So it's a topic we're going to come back to. Jerry, you've been in Africa over the last year. You've been in Kenya, and you've sort of seen a different type of vascular disease and metabolic problem. Most people, when they think of Africa, don't think about vascular disease or metabolic diseases. Talk about what your observations were during your time in Kenya.
So, it's well known, as Mark mentioned, that, chronic diseases are the #1 killers worldwide. If you look at all the regions taken together, sub-Saharan Africa as a region is different from the other regions because it's the largest killer is still communicable diseases. But if you
HIV being still a big one?
HIV still being a big one, TB, malaria. But if you look at disability-adjusted life years as a marker of the burden of disease in a population, it's #2, second to HIV and AIDS, chronic diseases that is, in most parts of sub-Saharan Africa. And so there's a real opportunity to prevent this storm of chronic diseases that we've seen in most parts of the world from happening in one region. In my own experiences in Kenya, the most common degenerative cardiovascular disease that we're seeing was actually hypertension. And as a result, I don't think we're at the acute MI coronary atherosclerosis phase of the diseases yet, but we do see a large burden of stroke. So I saw a lot of stroke
associated with untreated hypertension,
with
poorly treated hypertension.
Right, a lot of hemorrhagic strokes in relatively young people, and a lot of heart failure as a result of presumed to be hypertension.
Two diseases that really will drive the disability equation.
Right.
A stroke leaving you with a disability, obviously, particularly hemorrhagic stroke, high death rate, but maybe even worse, they can be disabling strokes. And hypertensive heart disease, as you know well, can be a difficult disease to treat and can be very disabling.
Right. And then the other part of the equation that is, again, unique to sub-Saharan Africa as a region is the large burden of HIV. And we know that HIV disease itself has cardiovascular complications, as does HIV treatment in terms of dyslipidemia, dysglycemia. The largest number of people in the world with HIV are in sub-Saharan Africa. The largest number of people who are dying from HIV are in sub-Saharan Africa. And so there's really a burden of cardiovascular disease that we haven't really had the opportunity to explore worldwide yet in sub-Saharan Africa. And the projections as people get older, they're on HIV treatment longer, they're becoming older and developing some of these chronic diseases, there's really expected to be a huge influx of chronic diseases into health systems, as you mentioned earlier, that are not quite prepared to deal with this type of disease treatment modality. The treatment schemes are usually, you come in for an acute episode of illness, and that's how the health system is set up. But you really need a chronic disease model to approach these things.
And that is really different, right? I mean, if we think about the medical missions that have gone to many countries, if we think about the public health approach, it's been either trying to prevent things through vaccination, mosquito netting, et cetera, or it's been to try to deliver episodic care, and then people go away. But what you're saying, Jerry, which I think is a really critical point, one of the things that has to happen in some of these countries is a transformation of the healthcare system to accommodate how do you follow people with chronic illnesses. Is that fair?
That's very fair, and a recent Institute of Medicine report says that exact thing.
This was the Val Fuster authored report?
Exactly, the Promoting Cardiovascular Health in the Developing World, which called for, and it's very interesting, you know, in global health, you know, it's not that chronic cardiovascular diseases are competing with HIV, TB, and malaria to get center stage, but there's been a lot of development of health systems, health centers, drug delivery schemes in many parts of the world built on the foundation of HIV, TB, and malaria. And it's the opportunity for the cardiovascular community to join in with that and to make use of an infrastructure that already exists to deliver chronic care.
The HIV one is an interesting one. As you know, that the NIH has had an emerged interest from the vascular disease perspective in HIV. In fact, there was a workshop last year on HIV and coronary disease. So this may be another example where there's that bidirectional information that we may learn a lot more from our African colleagues about the interplay of HIV and atherosclerosis than they might learn from us.
Completely.
Talk just a little bit about and remind our cardiology audience, because this is something that they will see, the treatment of HIV. You've alluded to the fact that it can have some metabolic and coronary abnormalities associated with it. Talk a little bit about that, because you can see diabetes, you can see lipid abnormalities.
Well, it's interesting, and this is one of the byproducts of being on the ground for a year last year as part of my cardiology fellowship, is that my initial interest actually has not been HIV and cardiovascular disease, but the large burden and a huge number of people with HIV, and you know, they develop hypertension, stroke, some with MIs, just forced me to sort of read into the literature a little bit more. So we actually did a study over the past year looking at cardiovascular risk factors in HIV-positive individuals. Even prior to HIV treatment, HIV itself has vascular effects, even in children, different arteriidities, atherosclerosis in the peripheral arteries, in the carotid arteries, some coronary as well.
So you see vasculopathies in kids with HIV disease?
You do, definitely, and that's been reported even prior to antiretroviral therapy. And antiretroviral therapy itself and protease inhibitors are the class of drugs that are most largely implicated, have effects on dyslipidemia, dysglycemia, lipodystrophy, body fat distribution, increasing obesity, higher BMI. So you add that to a population that may not have a large number of baseline cardiovascular risk factors, but then if you forecast, you know, once someone starts HIV treatment, they'll be on it for the rest of their lives.
It's definitely a different disease, isn't it, than it was 20, 25 years ago. It's a chronic disease.
Right.
And it's going to carry all the burdens of a chronic disease.
Right.
Let's go back to you, Mark, and ask the question, why should our Western colleagues from Europe, from the United States, Australia, New Zealand, countries that have very developed healthcare systems, why should they care about what's going on in the other areas of the world? Now, I say that a little, you know, sort of provocatively.
Sure.
You know, our social contract as human beings is that we should care. But I think it's more than that, isn't it?
Right. Well, one, it's, as you're saying, going after where the diseases lie. So 80% of the deaths occur in low and middle income countries. So that's one reason. But
so if you want to make an impact, that's where the impact is.
Right.
Okay.
Right. Second is, I think, this concept of you have access to innovation. So whether it be a polypill or community health workers or new things that are happening that are occurring all over the world, if you're engaged with partners overseas, you're likely going to be able to bring that back to the U.S. sooner. So that may be a real pragmatic sort of thing.
Let's just talk about that for a second,
Sure.
because I was struck. My wife had traveled to India last year as part of a research training program.
Okay.
They were delivering research education. And she was struck by the fact in visiting hospitals that virtually everybody has a mobile phone. And the mobile phone becomes the medical record number. And she was struck by the fact that for follow-up in clinical trials, et cetera, in many ways it might be easier to reach people in rural India than it is in the United States. Had you noted things like that?
Everybody has a cell phone, definitely. And that's one of the ways in which we've been able to follow people up in some of the studies that I've participated in. And I think I've talked to Jerry about this before. If people don't have a cell phone, they have a SIM card that they'll sort of trade in and out. So it makes communication for whether it be healthcare or health research a lot easier, at least in theory.
So there are some innovative models just by necessity that we can learn from and take back here.
Yes.
What do you observe in Africa, Jerry?
So it's the same paradigm. everyone in sub-Saharan Africa, the penetration is greater than 90% of cell phone technology. And it's interesting, if you go out into literally the bush or the much less developed areas, you'll have families of people who have one cell phone and a charger, but everyone will have their own SIM card that has their own address book and their own telephone number.
And they switch them out.
And they switch them out. And one way that we've been able to make use of the natural experiment, if you would, is chronic diseases are a little different from communicable diseases because there's a large chunk of lifestyle intervention that we would like people to adopt. And so health education, motivational interviewing, things like that are part of your armamentarium for treating chronic diseases. Well, how do you do that if you're at a health center in a major city and most of the population doesn't have access to roads? So we're looking at SMS technology in a bidirectional way as a health education tool for chronic diseases. And you said it perfectly, that model of healthcare delivery, there's no reason that can't work in Durham or Chicago or anywhere else in the developed world.
No, it's interesting. I've spent some time at these meetings talking with colleagues about the problem of adherence in clinical trials. That now, when we were doing a lot of trials thinking about acute care, 30-day endpoints, well, you could pretty much guarantee that people would stay on the therapy assigned for those 30 days, and many of the medications were a couple days. Now as we begin to follow people with lipid-lowering agents, antihypertensives, antiplatelet agents over 2, 3, 4, 5, 6 years, we're seeing 10, 15% of people drop out every year, not taking the study medication. And so one of the things we're starting to talk about is how do you convey to people the importance of this, and some of the educational tools you're talking about might be germane. How to reach people, how to stay connected with them, and a way to study maybe the social networking concept as a mechanism of communicating people in clinical trials. Yeah. Let's shift gears a little bit and talk about the two of you and your training. You're both obviously interested in global health. You've gone to different areas of the world to really immerse yourself in the local culture, the medical culture, the social culture. Talk a little bit, maybe start with you, Mark, about the opportunities for young people. And you said off camera that this is not going to be an old person's game, right? You're not going to get the associate professor, I think you said, to up and leave his or her lab. So you really want to make an appeal to young people training.
Absolutely.
That there's an opportunity here for a career.
Right. Well, I think Jerry and I came to this field at a very opportune time because now the NIH has funding for postdoctoral research fellows through a program called the Fogarty International Clinical Research Fellows Program. There's also a scholars program for interested medical students. There's a Fulbright program for medical students, but I think for people at the fellow level looking to, what type of research career do I want to have, there's definite support from the NIH.
So there's opportunity, there's work to do, good work to do, and there's potential funding mechanisms.
Right, and I would say really the fourth thing is the mentorship that I had in India was excellent and very complementary to the mentorship that I have here in Chicago, where I got to not only learn about the epidemic of cardiovascular disease in India, but from really the leaders within that country. And it was a real great chance for me to get to work with them and to build relationships for ongoing research.
So you really see one of the strengths, if I'm interpreting your remarks correctly, of a global focus of your training, that you really get exposed to team mentorship.
Yes.
You have mentors at Northwestern.
Yes.
Mentors in Delhi.
Yes.
Who are all coming together. And how do they connect so that they make sure that you're getting what you need to get?
Well, it's a little bit, sometimes my mentor, Dr. Prabhakaran, came to Northwestern to meet with Dr. Lloyd Jones and Dr. Bono. Dr. Bono's been over to Delhi with me. And then there's video conferencing because Skype is very easy. So just bring the laptop around and everybody can Skype on the same
Another
time.
example of people being a little more used to using technology to connect.
Right. So I think it's regular emails, telephone calls, Skyping, things like that. And that's the part where I get to play a little bit of the glue between the two. And that puts a little responsibility on someone at our level, but that's what we want. We want that opportunity to be able to build something that's a little new for both groups.
Jerry, how about you? What sort of experiences would you highlight for the audience, and particularly the young investigator or the trainee, as being a positive for training in global health?
Well, I think the take-home points, and Mark and I have discussed this as well, is that number one, it's possible. Neither of us are at an advanced level in our career, but we've had great mentorship and some initial successes, and there's more and more interest on the part of the NIH in funding careers along this line. So a lot of trainees who are interested in global health issues, they receive the advice that I know I received, and perhaps Mark received it well, that you should do infectious diseases because that makes sense. And it doesn't have to be that way. And some of the practical tips on how to have that happen, and you know this well, my mentorship panel at Duke University draws from the cardiology division and the DCRI, but as well the Global Health Institute and infectious diseases. And each part of that circle of mentorship has their own expertise that they bring to the table. The other part of it is my mentors on site in Kenya at Moi University. And spending time in a one-year experience as part of the Fogarty Fellowship Program not only allowed me to get direct mentorship in terms of how to perform clinical research in Kenya, but also allowed me to see some of the other cardiovascular diseases that were important. We talked about HIV earlier, and that wasn't on my radar. But it was working with my mentor in Kenya, Dr. Kamayo, who helped to expose me on some of the overlap between HIV and cardiovascular disease. The way that it happened in my particular case, and maybe we'll get to this, is an NHLBI-funded mechanism, the Centers of Excellence program, that allows the two mentorship teams to come together and communicate not only about my career development, which I'm glad that they do, but also about the Center of Excellence, because they're both partners in this center, and I'm part of that center.
So ways to bring the not just the trainees, but sort of the programmatic evaluation of what they might do together in the research world.
Right.
That's going to bring me to the last topic I want to bring up, which both of you have alluded to, this bidirectional flow of information. And certainly one of the challenges of moving to a globalization of these diseases is that they need to be studied in a global way. As you know, Seth Glickman and Kevin Schulman from our group have a paper in the New England Journal last year on this topic of some of the challenges in the globalization of research. One of the big challenges is a dearth of well-trained clinician investigators in certain parts of the world, and people who are hungry for information. So what opportunities exist for our colleagues in India or our colleagues in Africa to get an exposure to clinical research training that they can then take back to their country and help their population?
Sure. So the NIH has released an RFA for what's called a D43, what's a research training grant across the lifespan, or NCD lifespan is the name of the grant. And it's designed for a low and middle income country institution to be able to partner perhaps with a U.S. institution, but perhaps with another sort of established institution for research training of various lengths. It's commonly postdoctoral research training, but I see that as a really good mechanism. That there's been one round so far, and there's going to be another round over the next several years.
So bring some really bright, talented people to U.S. institutions rather to get really hands-on training, with the goal, I suspect, of that person or those people going back and becoming one of the leaders.
Right, and just like Jerry and I are getting this complementary mentorship, that person or those people could get similar types of mentorship that we've found pretty fruitful.
Jerry, from your perspective?
So definitely the D43 mechanism is an important mechanism for our colleagues in developing countries to get access to clinical research training. I would say there are two others that come to mind also. There's the National Heart, Lung, and Blood Institute Centers of Excellence program, where they're just actually started in 2009. There are 11 centers around the world that are the primary awardee of this contract with the NIH that's geared toward research and training of in-country clinician investigators. And so depending on the country you're in or the institute or university you're affiliated with, that's a way to get access to expertise in research and training. The other mechanism is one through the Fogarty program, and the Fogarty International Center has been the center pushing a lot of the global health agenda more recently. there's a GRIP award that developing country partners can apply for. And the details that people can look online, or they can contact either of us or yourself and to get more information. But it's a mechanism for scientists in the developing countries to get expertise, some in the U.S., some in their developing country, for PhD level training or other advanced level training, to return back to their home country and be the clinician scientist at their institute. A big problem, historically, and maybe somewhat today, is this issue of brain drain. And I think the NIH...
People come abroad and want to stay abroad.
Right, and then all the expertise in a country with little expertise to begin with is gone. And so I think the NIH has been very sensitive to that, and they've practiced global health research and training in a very sober way.
And I think the other thing that certainly from my perspective as someone engaged in clinical research around the globe is that we also have an obligation to, if we're interested in studying the diseases around the globe, also making sure there's adequate training as to how to study things.
Right.
And we need collaboration with individual countries where country leaders can really lead the effort, as opposed to sometimes with the commercial forces, they believe that they can just go into a country, do something, and leave. That's not appropriate.
Right.
We're really talking about training people who can become collaborators, which is, I suspect, what you guys are both getting at.
Right.
And I think my experience in Kenya was just that. I mean, my colleagues in Kenya are very sensitive to the fact that there are people whose interests are coming over, doing a research project and leaving.
Yeah.
And that's not what either of us are interested in. And so we really have to be held accountable and practice global health cardiovascular research in a way where everyone at the table has a say.
So we're running to the end of our time. Anything that we haven't brought up? I realize that there's probably many things that we haven't brought up, but is there anything you feel, boy, I have an opportunity to talk to an audience on theheart.org. I'd like to reach out to a few people. Anything you haven't mentioned?
I would say that these centers of excellence, while maybe not the only places to do global cardiovascular research, are really the best places, in my opinion, to do global cardiovascular research from a U.S. perspective.
So people should get on the web,
definitely.
Look at that.
The NHLBI, it's United Health, NHLBI Centers of Excellence. And these were pre-vetted Fogarty sites, so they're automatically places where you would be eligible to apply for a Fogarty fellowship. And it's in all continents except Australia and Antarctica. So
people who really understand and are committed to the concept of global health and have some experience in the cardiovascular realm.
Yes, go there or contact me.
Okay, good close, Jerry.
Well, and I was actually going to say the last part of that is that
contact you.
That's right. Well, or contact us. It's there are opportunities out there, and I think trainees at our level are getting more and more successes in pursuing global chronic disease research. Mark and I have, and I think if someone's as a fellow level or resident level, or even as a early junior faculty level who's interested in pursuing global chronic disease research, we could at least tell you some of the mistakes we've made along the way,
and tap
avoid.
Into that growing network of
Right.
young people who were doing this.
Right.
And I know that both of you were terrific when we had you on the Heart.org radio. We had a series of comments that you both graciously answered and tried to reach out to people who were interested. So we'll offer the same mechanism here, that if people want to leave a comment regarding anything you've said, that we'll be able to link back up to people. And the both of you have been very gracious to take the time to do that. Well, I want to thank the both of you. This has been a terrific conversation. Congratulations. I think you're both doing fabulous work. Your paper in circulation on the concept of training in global cardiovascular health is first rate, and we'll link to that from this video as well. There's been a terrific conversation with two senior cardiology fellows who have spent time, one in Africa and one in India, learning about global cardiovascular disease, and maybe more importantly, learning about how to think about chronic diseases in a global context. I hope you found it interesting. I certainly have. Please feel free to post a comment from Mark, Jerry, or I to think about and respond to. So thanks again for joining us on theheart.org.